Rahim. Autoimmune connective tissue diseases. These group of diseases have many clinical features and are characterized by dysregulation of immune responses and autoantibody productions. These include SLE, systemic sclerosis, dermatomyositis and polymyositis, and Sjogren's syndrome. The first one of them is SLE, systemic lupus erythematosus. Systemic lupus erythematosus, SLE is a multi-systemic disease affecting mainly young women, characterized by widespread organ involvement, a profound immunological disturbances with a tendency to exacerbations and remissions. The females are usually affected more than male in the ratio of 9:1. The age of onset is usually 10 to 35 years of age. As we have just said, it is a multi-systemic disease. So we study SLE in rheumatology, in dermatology, in nephrology, in immunology, in neurology, and in gynecology. The clinical features of SLE, mainly they are musculoskeletal 95%, cutaneous 81%, fever 77%, and other features. So the clinical features of SLE, the first one is the musculoskeletal features. It is one of the causes, SLE, of inflammatory erythropathies. So here we have an increase in the EMS, early morning stiffness. We have arthralgia. Arthralgia is seen in more than 90% of SLE patients. Tenosynovitis, non-erosive arthritis. Non-erosive arthritis. If deformities occur, they are due to tendon inflammation, not bone destruction. So one may have a swan neck deformity. This is called Charcot's arthropathy. It is due to tendon involvement, not joint destruction. The other feature is Raynaud's phenomenon. The other features are rash, dermatological features. We have a renal involvement, cardiovascular involvement, pulmonary features, neurological features, and hematological features. In hematological features, we have neutropenia, lymphopenia, thrombocytopenia, hemolytic anemia. The degree of lymphopenia is a good guide to disease activity. So, the degree of lymphopenia is a good guide to disease activity. And also we have a GI tract, mouth ulcers, mesenteric vasculitis, and etc. Now, the investigations in SLE. Diagnosis is based on a combination of clinical features and laboratory abnormalities. So we have an ARA criteria, American Rheumatism Association criteria. Here we have 11 criteria, Daesh criteria. Diagnosis is made when we have 4 out of those 11 criteria. At least so one should have 4 out of those 11 criteria. Patients should be screened for ANA, anti-nuclear antibody. Also, patients should be investigated for anti-double-stranded DNA, anti-double-stranded DNA. Double-stranded DNA. Actually, anti-DS-DNA are characteristic of severe active SLA, but it occurs only in 30% of patients. Low complement C3 and C4 levels, raised ESR, leukopenia, lymphopenia are typical of active SLA. CRP, C-reactive protein, are normal in active SLE except in the presence of coexisting infection. One of the classical features in SLE are high ESR facing a very low CRP or even negative CRP. Now, the management of SLE. One should avoid sun and ultraviolet exposure, control hypertension, control hyperlipidemia, stop smoking. For mild patients with symptoms restricted to the skin and musculoskeletal feature or system, one use non-steroidal anti-inflammatory and one may add anti-malarious hydroxychloroquine. Particularly are useful for patients predominantly with the skin and musculoskeletal features. These are enough. The other line of treatment is corticosteroid. Actually, prednisolone is the cornerstone of management for SLE. One can use short course prednisolone. For life-threatening disease affecting kidneys, CNS, and cardiovascular system, one should use steroid and one may add immunosuppressive therapy. As regarding the steroid, one can use the pulse steroid therapy. Pulse steroid therapy by intermittent bolus doses of methylprednisolone 1 gram IV for 3 successive days. This pulse steroid therapy can be repeated after 3 to 4 weeks. The other line of treatment is a plasma exchange. It is called plasmapheresis. Now, antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome. Davidson, page 977 صفحة 977. Antiphospholipid antibodies represent a distinct class of autoantibodies that are seen in about a third of SLE patients, but can also be present in individuals who don't carry the diagnosis of SLE. So, antiphospholipid antibody syndrome, APS, it might be seen in isolation called primary, or it is seen in association with other disease, usually SLE. The clinical features of antiphospholipid antibody syndrome are studies under 5 letters. T-A-T-A-N. Tatan. Tatan. Tatan T, the first T is thrombosis. Thrombosis one could have a venous DVT thrombosis or an arterial thrombosis. T, thrombosis. A, abortion. One of the cardinal features of antiphospholipid antibody syndrome is abortion or repeated abortions. The other one, thrombocytopenia. The other one, anticardiolipine antibodies. And the last one, neurological findings. Neurological might be stroke, might be transverse myelitis, and etc. So we have Tatan, T-A-T-A-N, Tatan، يعني لغرض التدريس والسهولة. So it is the condition of repeated abortion and thrombosis and neurological and anticardiolipine antibodies. Now, the management of antiphospholipid antibody syndrome. The management, asymptomatic patients, here there is no need for treatment apart from anticoagulant therapy during periods of high risk, like in pregnancy or operation. So here we use anticoagulant in the periods of pregnancy or high risk operations. Patients with venous thrombosis, here we need long anticoagulant therapy. For patients with arterial thrombosis, there should be a lifelong warfarin. Now, pregnant ladies with APS يعني antiphospholipid syndrome. For those ladies, one use low dose aspirin once a pregnancy test is positive. So one start with low dose aspirin once the pregnancy test is positive. This should be changed to low molecular weight heparin. So low molecular weight heparin is started once the fetal heart sound is heard by ultrasonography. This warfarin should be continued and discontinued at the 34th week of gestation. So it should be stopped at the 34th week of gestation. Another topic, systemic sclerosis. Davidson page 1037 صفحة 1037. Systemic sclerosis, also it is called scleroderma. Here it is a chronic systemic disorder of unknown etiology characterized by thickening of the skin. Thickening of the skin, it is called scleroderma, with multiple internal organs involvement, mostly lung, GI tract, heart, and kidneys. The progressive visceral organ dysfunction is due to fibrosis. The presence of thickened skin between brackets scleroderma distinguish systemic sclerosis from other connective tissue diseases. The scleroderma might be localized or it might be generalized. So one may have a diffuse cutaneous or limited cutaneous involvements. Also, this condition is associated with Raynaud's phenomena, with skin induration, with calcinosis, calcifications, with esophageal dysmotility, with sclerodactyly, with telangiectasia. A condition called a CREST syndrome, C-R-E-S-T. A CREST syndrome. C. Calcinosis, R. Raynaud's phenomena, E. Esophagitis, S. Sclerodactyly, and T. telangiectasia. Clinical features of systemic sclerosis: skin thickening, a dry skin, taut and shiny skin, microstomia, small mouth, microstomia, beak-like nose, telangiectasia, calcium deposits in the skin and soft tissues, GI tract involvement, esophagitis, stomach and small intestinal involvement, with prominent atrophy and fibrosis of smooth muscles. Esophagitis may lead to stricture, and we may have pulmonary features. We may have a renal involvement. The musculoskeletal involvement, here we may have arthralgia, carpal tunnel syndrome, median nerve entrapment in neuropathy, joint stiffness and restriction of movement, tendons, leathery crepitations, X-ray may show soft tissue calcification. Chest X-ray, one may have a pulmonary fibrosis, which may lead to pulmonary hypertension. A treatment of systemic sclerosis. Treatment of systemic sclerosis. First line is skin care. Skin care. For scleroderma, renal crisis is considered to be a medical emergency. Scleroderma renal crisis will lead to malignant hypertension. So it is considered as a medical emergency. Here it is treated by AC inhibitors. And one should avoid non-steroidals and steroid. Now, another topic, polymyositis and dermatomyositis. Polymyositis is an inflammatory disease of muscles, skeletal muscles, non-suppurative inflammatory disease of skeletal muscles. If it is associated with the skin involvement, it is called dermatomyositis. So if it is restricted to the muscles, it is called polymyositis. And if we have an additional skin involvement, it is called dermatomyositis. Polymyositis can occur in isolation or in association with other connective tissue disease as SLE, systemic sclerosis, Sjogren's syndrome, or it might be a feature of a hidden malignancy. So polymyositis might be a feature of a malignancy. The clinical features of polymyositis are proximal muscles weakness in upper and lower limbs, difficulty in rising from a chair, a climbing difficulty in climbing stairs, and lifting objects by the upper limbs. Later muscles wasting, contracture, and calcinosis of the muscles. So muscle weakness is a marker of disease activity. In dermatomyositis, in addition to skeletal muscle features, we have skin involvement, including gutturals papules on the proximal and distal interphalangeal joints. So, gutturals papules and the proximal and distal interphalangeal joints. In dermatomyositis, we have skin features in addition to muscles involvement. We have a gutturals papules on the proximal and distal interphalangeal joints. There will be a heliotropic violaceous discoloration of the eyelid. Heliotrope violaceous discoloration of the eyelid with periorbital eye edema. Similar rash and shawl distribution in the upper back and chest and shoulders. This area is called shawl region, shawl distribution. So we have a shawl distribution, a skin lesion, violaceous discoloration. In dermatomyositis and polymyositis, there is an increased risk of associated malignancies, which should be searched for. Investigations include muscle enzymes, CPK, creatinine phosphokinase. This is elevated in polymyositis and dermatomyositis, and also it is elevated in other group of disease, in myocardial infarction and others. EMG is useful, and muscle biopsy. Treatment of polymyositis. 1. Corticosteroid. High dosage systemic corticosteroid in adults. 1 milligram per kg per day, up to 60 milligram per day to start with, till enzymes are normalized, which may take several weeks or months. Then corticosteroids are reduced gradually to a maintenance dose therapy. Some 5 to 10% of patients may not respond to steroid. Here an immunosuppressive therapy should be added. Now, physiotherapy. Physiotherapy has an important role for restoring muscle strength and joints range of movements. Sjogren syndrome. Sjogren syndrome, page 1038 ألف وثمانية وثلاثين. Sjogren syndrome, it is a combination of keratoconjunctivitis sick, يعني dry eyes, xerostomia, dry mouth, and a connective tissue disorder, mostly RA, rheumatoid arthritis. If the eye and mouth manifestations are present without connective tissue disease, it is called sick syndrome. It is an autoimmune disorder of unknown cause characterized by lymphocytic infiltration of salivary and lacrimal glands and other exocrine glands, leading to dryness, mouth dryness, eye dryness. The disease may be primary or secondary to other autoimmune disorders. Clinical features of Sjogren syndromes. 1. Eyes. The main symptoms are grittiness and soreness of the eyes due to reduction of lacrimal secretions, leading to conjunctivitis and even corneal erosions due to dryness of the mouth, of the eyes. GI tract features. A dryness of the mouth may lead to difficulty of swallowing. A chronic lymphocytic infiltration of salivary glands, lacrimal glands, and other exocrine glands in respiratory tract, GI tract, skin, and vagina.